Warren, Dixie, thank you for the invite, and everybody. I really appreciate being able to see everybody and meet everybody in clinic and elsewhere. It really is a pleasure being here, and it's been really nice to see the other presentations. I think there's so many important points and things that, it's a hard topic to bring up. There's a lot of kind of components to things that I do depending on the patients. And, we talk about gait studies, we talk about tone management, talk about inpatient rehab, we talk about outpatient rehab and school and early development and bracing and all of that, and sort of where to focus was a little bit of a challenge. So, I sat with Dixie for a little bit and we chatted through maybe some of the things that might be important. So we'll kind of touch a little bit on development. I'm going to utilize sort of early development as sort of an example, but I think it really carries through up until at any point folks are sort of developing as we go through, right? I mean, our 26-year-olds are still learning how to do things correctly. And so I think that there's a lot of applicability as kids are getting older to all of this type of stuff. And then we'll talk a little bit about exercise management. There were some hopes that we had when we were having our first discussion about what to bring into this and how the guidelines or what kind of guidelines we could give with this. I can tell you, as I went through and started working through it, it was a lot more unclear than I was hoping it would be. And so, it's quite a bespoke thing. I think there's a lot of discussion that needs to happen with each individual patient and kind of go through and the importance of all that. And so similarly, I don't know financial disclosures for this. When we think about development, there's a ton of things, right? There's so many things that each kid is supposed to be learning from the day they're born on through however long. And we can kind of consider them on these developmental curves, and is kind of how I think about it as we're going through. And, they're building. We learn one thing and then we learn something else and so on and so forth. And so we break them up into different areas, including fine motor, speech, gross motor development, all that. But you can kind of think about them as more of a curve, right? So where are we kind of starting and where are we going with this? We think about the growth curves really well, and we look at those every time we go in when we're younger. This is the Denver test that kids will get when they're going through neuropsych testing or they're going through early development for IEPs and that kind of thing. But you can kind of look at it in that gross sense. And if we really kind of take out the details of, are they sitting, are they walking, are they standing, are they doing all these things, and just think about it in a more sort of broad sense, how are we moving forward, right? And that's sort of the expectation here is, are we moving forward? And we have our typical growth curves that we expect to see as kids are going through. And they interrelate. When we're thinking about this stuff, it's not in a vacuum. And so we anticipate that how we're developing in our gross motor is going to have implications in terms of how we're developing in terms of our fine motor control, and how we're developing in our speech, and how we're doing with our feeding, and whether or not we're able to get enough food in at each individual moment here and there. And so this is how we kind of think about it. And one of the biggest things that I think comes up is kids are on a different growth curve, right? So we've taken our gross motor and we've put it into a different place, right? They're no longer at 6 months sitting up, but they're doing something different. It's taking them a bit longer to develop those skills, whether it's due to tone, whether it's due to that early white matter disease that we see in our young kids, or maybe they did have a stroke, or they had something else that caused an effect, or they were just having other medical issues and they were in the ICU and in rehab and in bed for a year, and it took them for a really long time, or the prune belly is making it difficult for them to roll over and develop those early skills. And so they're learning things on a different time frame. And what ends up happening is we end up not in this typical pattern, right? We're not sitting up at 6 months, thinking about our feeding, getting up a little bit higher at 9 months and reaching out and feeding ourselves. And so we start to have different sort of interactions between our different developmental curves. And so this is where I think a lot of times we end up having to have longer conversations about what are our goals at each moment, right? So when we think about what we're doing with therapy, what we're doing at that time, kids may not be ready to be sitting up. And so if we're putting them into sitting positions, it's going to have effects on how well they're able to utilize their hands, how well they're able to reach out, because they're putting a lot of energy into that and they don't have a nice stable base. And so it's going to affect their ability to feed. It's going to affect their ability to utilize that fine motor control. And so how do we help them develop certain skills that maybe they are developmentally ready for from a social standpoint, from a feeding standpoint, making sure we're utilizing their mouth at that appropriate time so they don't get oral aversion and those types of things. If maybe we're not quite ready from a gross motor standpoint to be doing those things. And that's, where we have to start thinking about our different therapies, where we have to start thinking about different accommodations and bracing and that sort of thing. And recognizing that, the feeding and that sort is a good example. If we need to be sitting up to feed, so we're safe and we're doing that, we're not going to be working on our gross motor. We're not going to be working on our truncal control at that point. We may be utilizing something like an activity chair or a Benic vest or something along in that realm that's going to give us that support, give us that stability so we can work on that part of development, while also recognizing that we still need to work on our truncal control. We still need to work on our ability to sit up and do that, because that's what's going to progress us through. We need to get our truncal control before we can pull the stand, before we can start taking steps and do all of those aspects. And so we're going to have to sort of have these conversations of what are our goals of therapy at certain times. And these are just examples, right? This carries through as kids get older. We may be thinking about, are we working on our gait development? How much are we working on our intrinsic foot control and our strength? Are we utilizing our braces at certain times? As kids start to stand, sometimes it's really helpful to have braces when they're up and they're standing, because they're older and they need to help work on their hip development and make sure that we're not getting hip dysplasia and that sort. But those same braces are going to get in the way of their transitions. They're not going to be able to go from laying on the floor to standing, because they're not going to be able to get enough dorsiflexion in that foot. And so when they're at home and they're working on that, we may want to take those braces off, give them that ability to start working on that transition, crawling around, moving around, exploring the world from a crawling standpoint. But then in therapy, taking that time and having them work with the braces, work on standing, work on being up. And it's really hard to say, like, this is what we're going to do, because it's going to be individual, right? It's going to be every time. And these are the conversations that you want to make sure you're having with your therapist, with your physicians, of what are our goals? What are we working on at this point? We have complex coordinated care here. We're also sort of lucky that we have a relatively small children's hospital within this massive research hospital. And so I do see most of my kids when they're inpatient. I pop by and see Raceland on his own on a regular basis and just say, hey, what's going on, as he's on his iPad and bouncing around and doing his thing. So, it's so important to kind of have this understanding of where a child is in terms of their development, how they're moving forward, and what we can do to help enhance that. And it really does need to be an individual basis. The accommodations versus learning is kind of the big discussion that I have on a regular basis with folks of how much are we trying to correct? How much are we trying to teach? How much are we trying to just make sure that they can do the things that they should be doing at that age? They want to be up, they want to be upright, they want to see their peers and be moving around and exploring. We had this conversation with Raceland, I remember, in terms of the wheelchair. He was ready to move. He was ready to get going. He wanted to go and see the world, but he wasn't ready to walk. He wasn't ready really crawling on that much. And so how can we give him that ability to continue to develop socially, to continue to develop in terms of an exploratory way, while still at times working on his ability to stand up and do all those other things? And so what's the accommodation that we're providing, and how are we thinking about our goals of therapy, right? We talk about goals of care on a regular basis with our palliative care folks. But goals of therapy are just as important, making sure we're utilizing those at different times. And that goes for bracing and equipment and sort of all the different sets. Sorry, let me come back one second. In this setting, we're talking a little bit more about what we would call habilitation. So there's different kind of ways of thinking about what our therapy is. And habilitation is really, how are we enhancing our kids' ability to learn new skills when that acquisition has either been delayed or they didn't capture it in the right time? What are we doing in terms of our early interventions, our outpatient therapies, the other things that we're doing there to help them learn something in the setting of development, in the setting of growth, in the setting of, they've never done this before. We're not rehabbing them to sit up. They've never sat up before, but they're 9 months. How do we get them to where they want to be? And so it's very different from what we may see in some kids when they have had a stroke and they were on a path and they were doing something well, but now we've dropped down and our function is different than where it was 3 weeks ago. And we've been in the ICU and we've been in through this traumatic episode. And so, there's a number of different ways of thinking about this, depending on the age of the kid, depending on the level of function and whatever deficits they may have at this point. after that acute episode, often we're having conversations of what is our next steps? Where do we go from here? Do we just go home and think about getting back into our therapy program that we had before? Sometimes that's the right approach. If we have a really robust therapy program, they're doing therapy multiple times, maybe we want to just get home, and that's going to be the best thing for you and your family. If they've had a big deficit, and I think for one of forgetting who was going to talk before, when we saw her last time, she had a big deficit right before, and so we talked about inpatient rehab, where it's going to be 3 hours of therapy a day. We're going to be working with all our disciplines, PT, OT, speech therapy, really trying to boost that up. And there's a couple different goals when we think about inpatient rehab. Safety is sort of the first one, and it carries through in a lot of different settings. We were just talking about G tubes and the set of feeding, right? Safety is often an easy answer. They're aspirating, they're not safe to eat. We really can't be giving them something by mouth. We should move to a G tube. And then there's benefit, right? There's function, there's the level of independence we have in the different settings. And what can we do to enhance that function, to enhance that independence, and move these kids forward as quickly as possible as we're going through. And sometimes, particularly after a stroke or other things, there may be a little bit of a time period that's more important, right? Once they've had that injury, there's this little time period where maybe we can make more gains right after, as opposed to over a longer period of time if we do that. And if we're able to increase the amount of therapy during that time. Comes with its own stresses, comes with not being at home, being in the hospital for longer periods and all of that part. But it also comes with its other benefits of being seen by a physician on a daily basis, having, nursing and all of those things. So if there are other medical issues that are still lingering, sometimes that's another reason that we'll think about continuing with inpatient rehab to try to get you back up. And that's kind of the goal here when we think about rehab, to enhance and restore that functional ability and quality of life. And I think that's a big discussion that I end up having. I think, at the end of the day, why are we doing a lot of this stuff? Why do we want our kids to stand? Why do we want our kids to walk? So they can go and have relationships, right? So they can explore, so they can learn things, so they can see new things in the world, and they can keep up with their peers and do other things like that. Because at the end of the day, great, walking is wonderful. And of course, we want people to be able to do that. But there's other benefits to it, right? There's social benefits, there's social interaction, there's family interactions, and all of those things. And that's where these accommodations, I think, become much more clear. It's much more easy to understand when you kind of take another step forward and say, okay, why are we doing physical therapy? Like, why are we putting all this effort in? Why are we sending our kids to these different camps and doing all these different things to get them to walk? Great, yes, it's to get them to walk, but there's also another step there. There's another goal that comes with those often, and that's where it's often a much easier discussion and decision to say, okay, maybe we do want to move to a wheelchair. Maybe we do want to do something. Our kids with Active 2 often get fatigued really easily. And so often it's really helpful to have a mobility device to get a walk to there. It's sort of silly to waste all of your energy getting to the aquarium and then be exhausted when you're there and not be enjoying the turtles and not enjoying all the fun stuff because you're so tired. Versus if we're able to give you that mobility device, get you there in a way that's much more functional, and then you walk around when you get to the aquarium and you get to see everything and you get to enjoy that time period. So that's how I try to think about these things, and those are kind of the discussions that we try to have as we're going through this on an ongoing basis. So I just talked to Dr. Carroll on his way out, and he had a very similar slide that was all the circles, but he had mitochondria in the center, which I thought was a perfect difference between a physiatrist and a critical care doctor. For me, the center is going to be the patient and the family, right? You guys are the experts here. I've heard a couple times, I have to be an expert. We were in clinic and somebody asked, what do I do? And it was sort of like, depends a little bit on what do you need me to do and where we are. We talk about function as being our role here. But then there's all the other expertise and all the other aspects. And one of the things that came up was that, when we come to these medical sessions and these things, it's often very medically based. And I think that there's a reason for that, right? I have a doctorate of medicine. That's my role. And I'm not the one that should be dictating all of the care here, right? There is a full team that needs to be part of this. And that starts with you guys and starts with the patients. It then goes to your home community and who you live with in your neighborhood and that stuff. And then there's also your community here, right? There's the disease specific community that's going to give insight into where we are and what we're doing and how things are working. but then also your specialist, your primary care doctor, your local specialist, right? That maybe aren't disease-specific specialists. I ran out of circles as I was going through this, but are going to help you in sort of the day-to-day management of how do we get through this? How do we actually know what we're doing? And then your therapist, your friends, you know, there's, we talk a lot about the F words recently we've been bringing to here. And, you know, there's different ways of thinking about what's important to your child. And is that your snuff, right? Sorry. It was like perfect, right? That baseline function is, I feel like half of what I do in my consults is to try to convince folks that these kids on paper that look terrifying have so much to offer and are doing so well. And I remember one kid, it wasn't an active two, but I went in and they were like, well, he's at baseline. And he wasn't communicating. At home, he had a girlfriend, he went to school, he did all these other things, and they were calling him at his baseline. And it's a huge detriment to their care, right? Because we assume that this is where they are. And we really need to advocate that this is not who they are. And this is the type of thing, and these are the type of people when you get to know and you have your team that's able to advocate for that and make sure that you're moving in the right direction for it. So I want to talk a little bit about what kind of therapies are available and how we utilize these things. It is a little bit hard. This is going to be a bit specific to what I know. We have an international audience, and so, you know, we see other folks with ML4, and, you know, the therapy models are different. School models are different. It's not the same across the board. And so I preface that this is sort of an example and how I think about these therapies and not necessarily what you should be doing or shouldn't be doing. Early on, you know, we know that early intervention for kids with any sort of deficits is really important. We want to make sure that we're getting them the supports they need early. And here it's federally mandated. Every state has it. You call, anybody can refer, and you're able to get your kids PTOT speech. They come out to the house, they do a full evaluation, and then provide whatever it is in terms of the deficits that they see. Often when they're really little, you're not necessarily getting all of these. They have folks called developmental specialists that will come out and sort of go through the process and just monitor, keep close eye, and go through this. Stroke is a qualifying diagnosis. And so these kids, regardless of the level of function that they are able to continue with this early intervention. And this often goes until they're 3. I really like this model. It gives us a lot of eyes. It gives people that know them well. It gives you that community that's coming into the house, seeing them on a regular basis and saying, are they kind of moving along in the way that we expect them to and are hoping for them to do? Then they're able to bring in as much stuff as they want. Massachusetts, amazingly, through early intervention, covers HIPAA therapy, which is unbelievably rare and not common, but wonderful for them. Aquatherapy is often hard to get here. It's not covered through there. You know, adaptive play is typically what therapy looks like at this age. We hear it on a regular basis that they're not really doing anything with my kid. They're just playing with them. And that's what they should be doing. It should be play. All of therapy at this age is really play. As they get older, so after 3 years old here, it moves over to the school districts. And this is where we think about our different ways of implementing services for children, right? And so there's 504 plans, there's IEP plans. The big difference is an IEP is going to be reevaluated on a yearly basis, and it's going to give them the ability to set goals. So you have goals, they should be moving forward. You're trying to make improvements as kids are going through the system, versus a 504 is really just accommodations. So it can be pretty broad. Somebody's the elevator, that falls under a 504 plan. They have a central auditory processing issue and they need guys. And they have to sit in a specific spot that can fall under a 504 as well. But often when we're thinking about that, you can do that. You have a yearly meeting, you meet with the whole team. You know, the biggest thing about the IEP is that you guys are in control of this, right? So you're going in and you're accepting or rejecting, you're having these conversations. And one of the biggest struggles that I find is that I think parents often think that it's a sort of all or none. right? They give you something and you look at it and say, I don't like that, and we're going to reject. Where the reality is there should be a conversation. You should be able to come back and say, hey, this seems great. I love a lot of parts of it. There's a couple things here and there that I'd like to change. If we can accept it and change it, it moves it through a lot quicker and it gets those services for that kid. The struggle sometimes, I think, with families and with therapies as we're going through is these are the goals, right? So the things that they're going to provide for kids as they're going through is stuff to help them access the curriculum. And they're really going to be school-based goals. So there are absolutely things like ADL stuff, especially in our higher functioning kids, that may not fit into therapy here. And that's when I start thinking about our outpatient therapies, right? And there should be separate goals for that. And as we're going through this, outpatient based, it can cause challenges within life, right? There's lots going on at this point. You're going to school, you have other activities outside of school, and then you're trying to pull them out of that stuff and go to therapy and get back. And it becomes exhausting. And that's where we try to really integrate into the community. Can we utilize other things? Can we utilize gymnastics, which we'll talk about later, maybe not a great example. Can we utilize other adaptive sports and other things that are going to get the kids active, going to get them moving, going to get them involved, while also allowing them to be socially engaged and meet with their peers and have play and all of the other things that go into the development of a first grader, of a second grader. There's so much stuff that's happening socially at that point, and we got to make sure that we're not pulling them out of school and pulling them out of class and pulling them out of after school activities so much that they're not getting that peer interaction, because it really is crucial around these time frames. So I'm a physiatrist, physical medicine and rehabilitation. Our goals here are often broad. And this is why I say, what do you do? It really depends on what do you need. We really are looking at just increasing our independence. What can we improve in terms of our mobility? What can we improve in terms of our activities of daily living, which is going to obviously look very different for a 2-year-old to a 15-year-old. We're going to expect them to be doing more. They're going to want to do more, and that's going to look different for our therapies as we go through things. Feeding, cognition, social interaction, I think, is one of the biggest ones to make sure that we're thinking about. It's one of the ones that's easily kind of passed over because we're so focused on what we can see. We're so focused on their gait. We're so focused on their fine motor, their use of their hands, and we're going to and therapy is very clear for those types of things. But we need to make sure that we're recognizing that the social development should be a purposeful thing that we're implementing and helping our kids kind of move through. And self-advocacy. As kids get older, depending on their level of function, we want to make sure that they're able to advocate for themselves and they know what their care is. And that's part of the transition as kids get older and into the adult world. And so really, at the end of the day, it's that quality of life. What is our end goal here? Why are we doing these therapies? Why are we thinking about improving the things that we want to improve? So sports, the other aspect of this was, what do we do in terms of activity? There's lots of components to Acted 2, and it gets a bit complicated when we start thinking about how do we restrict, what kind of things are we capable of doing, are we allowed to do, or safe to do, and those. Sports are a big part of young kids' lives, even if they're not athletic. There's so many other things, right? Again, back to that social component. They're learning how to interact, right? They both are 5 and they run for a ball and they get there and they are learning what the other person's doing and how do I interact when we both want to do something. That's what youth soccer is about. It's not about learning spacing and all the other things that go into soccer play, but really important. And there's lots of different ways of doing this. So adaptive sports, adapted typically from able-bodied versions of the sports. Adapted play is great. This is out front of Spaulding, which is over in Charlestown. So the Menino playground is pretty much fully accessible. And they've got wheelchair swings and lots of other stuff, lots of ramps, a soft ground that's not wood chips that our kids can get around on really easily. And this kind of stuff is wonderful for the community, and it really, enhances access and enhances inclusion for kids. And something that, I think should be a big part of other communities, but they're very expensive and it makes it a challenge. Para sports they went in parallel to the Olympics. So the Paralympics are parallel Olympics, not paraplegic Olympics, which gets mixed up. But there are able-bodied sports. There's also ones that are unique to the para athletes. And not everybody's going to fall into this category. Lots of kids will fall into able-bodied sports. They will play town sports. They will play with the community and locally, and they'll go through. Sometimes what we see as kids get older and it becomes more competitive, that's where we may want to move towards, or at least incorporate some of these adaptive sports options, so they can be competitive, so they have other peers that are doing similar things, and they're not feeling like they're fighting to be part of it, like they're fighting to continue with the other, fifth graders and sixth graders as they start to get really good at their sports and more competitive with things. So why do we want to do it? The facilitators, knowledge of health benefits and physical activity. There's tons. We want to make sure these kids feel active and they maintain an active lifestyle and they keep moving as they're going through. Motivation starts when they're younger, and there's lots of different evidence that's out there about that. And belief that physical activity is fun, right? We want to make sure that they see themselves as athletes and they see themselves as people that can participate in these types of things. And again, access to adaptive resources, being accessible and easy to get to makes it doable. This is what keeps people going out and doing the types of things and being active. But there are a lot of barriers, right? Decreased activity compared to age-matched peers. So our kids that have any sort of disability, when you look at their age-matched peers, they're just across the board less active. And then this, I think, is a big one. So the decreased diversity of sports participation. When you look at adapted sports, it's often not what kids do, right? There's so many parts that are what adults do, right? We move away from team sports as we get older, and we move much more towards sort of individual activities. We go swimming, we go running, we go biking, we go cycling, all of those types of things. And those are sometimes the easy ones that we think of when we think about adaptive sports. But kids want to do social stuff. They want to be with their peers. They want to be playing, and they want to have those team sports. And so looking into the community and either helping develop it, CP soccer has been a great part of what's gone on here in the States. And we're working on with Dr. Mussolino and Mara to try to turn this into a research-based aspect and proving the benefits that maybe we can get this covered by insurance to have more sports-based activity therapies, where it's not just you're going one-on-one with a therapist, but you're going and playing on a team, and that's part of your therapy. And how do we make that an option? And it's not always the activities they prefer. And I think that's the other part for some of our kids that are participating in adaptive therapies or adaptive sports. Soccer's available or cycling's available, and the kid doesn't want to do those things, right? My daughter's 7, and we've done a million different things. She hates soccer. She kind of likes lacrosse. She loves gymnastics. She doesn't like to swim. We've tried all of those things, and that's very typical for kids, right? They try lots of stuff, but when we only have 2 or 3 options, makes it really hard to try lots of different things. And maybe they're not available. They're across, in Boston, they're 10 miles away, which will take you an hour and a half to get to. So it makes it a little bit more challenging, but we want to promote this. We want to do what we can to facilitate it. And it falls on sort of everybody that's in the community, from the physicians all the way through. So what kind of restrictions do we put on? When I spoke with Dixie, my hope was to take, I've got 2 or 3 kind of charts of things that we have to think about for our kids and what kind of restrictions we're going to put on sports and what sports we can and can't play. I was hoping to sort of amalgamate them. It was a bit more complicated. And I think, one of the parts that makes it complicated is that, it really does depend on the level of participation, the intensity level, how much you're doing, how competitive it is. And so often a lot of these do fall into a discussion, right? We need to kind of go through it and think about your child, their deficits, their risk factors, and everything that's a component within very specifically to them. But these are sort of the things that we're thinking about. So contact is a big aspect of it, especially if we've had a stroke, if we have concerns about any sort of bleeding or head injury and that sort of thing. I break contact into into 2 different component or categories, I guess. The first would be collision sports. Collision sports are sort of the point of the sport is to collide, right? So American football, ice hockey, men's lacrosse, rodeo gets put in there. Kind of a no. This is pretty much like an off the chart, no, these are not going to be safe, not recommended, not something we want your kids participating in. And that has some implications when they're younger, right? Flag football, probably okay, but if they love flag football, it's going to be really hard to pull them out when that stops being an option. So you do want to sort of think about this a little bit when they're younger and think about what implications this is going to have if they really do fall in love with a sport that you're going to tell them they can't do in 3 years. Limited contact, it really does depend. I think soccer is a good example within this realm of soccer's probably fine. Heading the ball at a competitive level, probably not fine. Not fine. We'll just leave it at not probably. You don't want them doing that. And, most of our young kids are not heading. They're not allowed to, but it's something that, again, as they move forward, you absolutely can play competitive soccer and not head the ball and not be part of your play. But again, that may have implications in terms of your position, right? Goalie is going to maybe be at a higher risk for all those corner kicks when they're going up. Head-to-head impacts are actually where we see most of the injuries within soccer. And so we want to make sure that we're being thoughtful about where we're putting our kids and where we're putting them at risk potentially. And then our non-contact sports. From a contact point of view, all okay, right? These are going to be safe for your kids. Problem is, as we're going through, we have other things to think about. So we have cardiovascular risk, right? We have concerns about our ability to maintain our blood pressure, to self-regulate what that blood pressure is as it's going through our body. And so there's a couple different ways of thinking about it. And I think two components of it. One is that regulation of our blood pressure. The other is the potential risk for aortic dilation. And what does that mean? And what kind of restrictions should we put on that? And so this is a way of looking at sort of different sports in terms of the amount of energy or effort or intensity that you're going to be doing. So sort of dynamic component, static component, high and high, low to high, low to high. And so obviously our low, going to be nice and safe. And I pulled up an article from, when was this, 2013, aortic root disease. Honestly, I feel like I didn't think about this initially as I was going through and put it in later, because I usually am putting these types of restrictions on our cardiologists to talk to the families about. But we really want to be avoiding probably these high intensity sports. So the ones that fell into that category, at least in this article, were like boxing, gymnastics, powerlifting, where we're going to have that really strong static component. Those types of things are not going to be great. Cycling falls up here. I know we've had conversations about cycling in this with folks in this room. Again, what's our level? How much are we doing? Is it highly competitive? I think this probably falls into the cycling component of like track cycling, where, folks' legs are this big and they're really pushing the whole time. And it's a huge burden and a huge amount of blood flow that's coming through and energy expenditure. Versus, are you riding a cruiser bike down to the beach? Probably very different component, right? Not something that we would necessarily restrict on. And so, again, it's all, I think, a conversation about what do you want to do and what are deficits, what has happened. I'd be curious what you think afterwards, Mark, like if we don't have dilation of the aortic root, if we don't see changes, are we still restricting in this disease on the expectation that might come at some point, or are we injuring that? Probably, right? So, it all sort of gets a bit more complicated, and there are certainly restrictions. Even though we really want these kids to participate and play in sports, we also got to balance that safety and that sort. So the last part I wanted to talk about was helmets. My kids wear helmets in everything. They're the kids on the sledding hills with helmets. They're the kids on their scooters with helmets. They wear helmets. I think each one of them has at least 3 helmets for different things, from skiing to biking to, what is their other one? They have another helmet for something. Anyway, super important. The one thing that I do want to bring in, so they should wear helmets regardless of what they're doing. But when we think about what helmet, depending on what we're doing, the one thing that I do want to bring up is, with this, we do think about shear forces a little bit. And there is some technology out there that can help us reduce the shear forces if we fall in the neck and that sort. It's called MIPS, M-I-P-S. I looked it up before and I'm forgetting exactly what it stands for. But essentially, what you see here is there's a component within the helmet that actually attaches to the head, and then the helmet sits on that. So when they hit, you get that force protection of the actual injury, but you also get a little bit of motion. It's up to, I think, 20 millimeters within that helmet before it actually hits the body. And so you're not getting that same shearing force. And you can imagine here when we land, there's going to be a shearing force on that neck, on the head. And with this, you're going to decrease that risk as you're going through. And so we've recommended this. They're out there for bike helmets, for horseback riding, for hockey, all of those things. And it's not, this is not like a specific company. I think it's at like 15 or 16 companies now are utilizing this technology within their helmets. And I think it is one of those things that I would look for when we're getting helmets for our kids, that we probably want kind of the next level up and not just that blank foam protection as we're doing things. So to summarize to some extent, our exercise recommendations: monitoring body temperature to avoid extremes. We want to make sure that we're not overheating. We really want to be thoughtful about our ability to sort of dispel heat and that sort. I know cold is often a big issue. Somebody here forgot the wetsuit, so we were not happy. So making sure that you're being just thoughtful about that. Avoid high intensity, right? So that's where I say like gymnastics gets put in that category. Boxing, for multiple reasons, we shouldn't be doing. But tackle football, competitive soccer, again, I think that we have to be thoughtful about what that means in terms of what level of they're doing. I think that 6-year-old soccer is absolutely okay. Probably up through 5th grade, we're probably still okay. It starts to get much more competitive. And I think being thoughtful about what position we're playing, if we really want it, how much we're going up for head balls, that kind of stuff can be a discussion. Rugby would be a no-go. Consider individual physical needs, awareness of individual activity restrictions. So there's going to be differences depending on your child, right? What has happened in the past? Where are they? What do we need to be thinking about from a cognitive level, from a physical? Are they going to be able to maintain those restrictions if we do put them into certain sports? And being thoughtful there. Teaching them and making sure that they're aware. I think almost all the kids that I know are really good about self-advocating and taking breaks when they need to, but making sure they're aware of that and then avoiding that dehydration, right? It's usually the hardest thing, especially as kids are younger. Making sure they're drinking water, utilizing the special bottles and all the different things that you can do, but making sure they're drinking as they go through stuff. And that is one of those places where I think, we can talk about the IEP and 504s of making sure they're allowed to have water bottles with them and that kind of stuff to help protect them. Assess and monitor cardiovascular risk, so avoiding isometrics, so weightlifting type stuff, increased activities with increased static component, uphill bicycle riding is what I was talking about. How much are we really pushing on this? And then allowing for frequent breaks. The other component that I didn't really talk about is sort of the G forces, unknown twists and turns. We don't want to be turning a bunch. It's a little bit falls into those MIPs in the helmet where we want to avoid that shear force on the neck and then carotids. And this is probably, I feel like, I think this is probably true for every kid. I hate trampolines, but there's other reasons to be thoughtful of them. I think that kids can go in bounce houses when there's a million kids in there and they're all older than your child, probably not a great place for them. But when they're in there with, younger kids and with a few kids, then absolutely okay. But just being thoughtful. So thank you. And I put this in, I think you guys will have the slides and stuff. Just a list of examples, just things that we have available here that are mostly local. Adaptive Sports New England, NASA does a lot of skiing. Adaptive Sports does some swimming stuff for kids. Go Baby Go was out of University of Delaware. It was one of the things I trained. Did Graceland end up getting a Go Baby Go? We talked about it, right? A different version. It's like a little kid cart that they make mobile for our younger ones that aren't quite ready for a wheelchair. Enabled Play was a older brother of one of my patients who developed essentially this program to help for adapted video gaming and that sort of thing. So there's stuff out there. Boston Ballet does stuff. What was the other one I put in here? Enabling devices is a lot of like music and musical instrument, adapted musical instruments and that sort. So like I said, there's the things that are obvious for adapted sports and other adapted things. All kids aren't the same. A lot of kids, whether it's art or music or something else, thinking about your kids' interests and making sure that they're able to participate those like any other kid would. That should be the goal here. And that's what we should be moving towards. So, all right. Thank you.
Any questions for Dr. Wishart?
I have a couple. Why is gymnastics an issue? Is that just on a high level and recreational is okay, or what is the impact of that?
So, I can tell you, I always stressed about gymnastics. So my daughter's 7.
Yeah.
I always was like hardcore against it. I see a lot of injuries. So once kids start going, and it's not too late, right? It's pretty soon after they start that you can have some pretty high impacts. They're upside down, they're on the bars, they're doing the floor stuff, they're bending their backs a ton. So I think that your risk of impact and contact is really high. And then I think from a cardiovascular standpoint, it's often, especially when you start moving up at all, actually relatively high intensity. And so it does put us at a cardiovascular risk from the aorta. I have moved a little bit on it. I think that for our young kids, like tumbling and that kind of stuff is actually one of the best things for body awareness, for proprioception, for intrinsic foot strength, and getting kids to just be generally stronger. And so some of the recommendations I've seen is that like our really young kids, probably a great activity for them. But then as they get older, and by older, I mean like 6, 7, moving a little bit further away and doing more of the team sports and doing more of like trying everything as you're going through, and then you can sort of specialize as you get a bit older. So the younger ones, I do like it because I think that there are being thoughtful, right? Tumbling, putting like your 2 or 3-year-old in tumbling where they're learning the basics is fine. I think it's more the bigger ones where you're working on bar work and back bends and handsprings and all of that jazz. The other thing that I like about it, most kids are gonna, especially like my daughter, the reason I was like, all right, fine, let's do this, because she was doing cartwheels in the playground anyway, and she was terrible at them, and she was gonna get hurt, and so you might as well learn to do them correctly. So I do think there's a little bit of play in that. Like if they're doing things in a dangerous way, then let's try to get them to do this safely. But yeah, I think as you get more competitive, and the reality is that gymnastics gets competitive really quick.
Yeah. Right now he's doing everything assisted. So once he has the ability to not do it assisted would be a good time to move away.
Yeah.
How do we keep our kids as healthy as possible cardiovascularly if they can't do the high impact stuff? I mean, general exercise recommendations are to exercise. So what do we do?
Everything else, right? I mean, honestly, like walking is the best thing you can do from like a cardiovascular standpoint. So most people that are looking to not lose a ton of weight are just doing a lot more walking or low impact, So I think just maintaining that activity. So, there's that huge list of non-contact sports and stuff. There's so many other aspects that we can get kids involved in that we sometimes just don't think about because they're not right there accessible. But I think if you get them involved and make it feel special, they can get really excited about things like golf and other stuff there. We want them doing those other parts like the soccer and the running and that sort. Basketball is great. Like I think there's lots of other things that are out there. There are a number of restrictions on these kids, unfortunately. But keeping them active, getting to the playground, being outside, that kind of stuff. Yeah.
Okay, last one. Where can we get an IEP resource to take back to our schools to say these are the accommodations that they need or could need? Like, I don't know what to tell my school, this is what he needs, but I know there are several recommendations.
Yeah. So I would, there's a number of ways that we go about it. One, when you meet with your school, they're going to do a full evaluation. And so they're going to go through, and then part of that IEP process is sitting down with their PT, their OT, their speech therapist, their neuropsychologist, having a full discussion about where they exceeded, where they did well, where they didn't, and that part to say, okay, this is what we need to help them with. The other component, and we do this frequently, is try to get a hospital-based neuropsych done. And the nice part about that is it pulls in the medical history that they don't have when they do it from the school side, right? They don't know what his history was. They don't know what he's gone through. and everything. And so when you have that hospital-based neuropsych that has that, you're able to bring that to the school and do it. And then I think having a discussion with your physicians, I think Dr. Mussolino has jumped on a number of IEP meetings to kind of discuss what these kids are going through and how much they are, how important hydration is, like how crucial that is to their well-being. So yeah, the schools will do a number of it, but there's other resources that are out there. And I think your physicians, and then the neuropsych is really helpful. They can start that at age 3. And then we usually don't do it more frequently than every 3 years because they learn the test and it just becomes invalid.
Dr. Wishart, I have a question. Different ages have different abilities, different needs. You have to adjust as you went through what might work when they're younger, might not work when they're older. So for some of us, our kids have gotten older. Avery's 13. She's not the only teenager. And it becomes where social activities start to become more of a challenge because they can't keep up at the competitive level. So for some of the parents that this may be coming your way, and for those of us that are already here, do you have any suggestions, not just about the activity, but how do you talk to your child and get them, like you said, there's limited things. So if she wants to do one event or activity that all her friends are doing, and you say, well, you can do this activity that is not going over so well. Do you have any suggestions of how you have that conversation with the child? And do you want to talk to Avery when we're here? I'm kidding, but it's a good question.
Palliative care folks. No, I mean, we just had a conversation. We just had a session through our pediatric stroke group on talking to your child about their illness and that sort. And it's hard, right? I mean, being 13 is hard no matter what. And then telling them they can't do things that their friends are doing. I think trying to accommodate and trying to recognize that them being part of that group is really crucial to their development. And it really does mean a lot to them, even though it doesn't feel all that important. To you as the parent, it may seem like not as big of a deal, but trying to work through some of those accommodations. And I think that's what I was talking about on that front end of what are our goals here, right? Why does she want to participate? Why does she want to go do that? Is it so she can be with her friends? Or is it because of something, right? Trying to kind of work through that maybe with them of like, what are the goals here? And if once you can kind of figure that out, I think it makes it a bit easier to figure out what accommodations are going to help them be content with their level of participation in it. And then recognizing there's probably going to be moments where you're just the bad guy.
I just have a quick question. So your charts were like a little confusing to me. Are you saying no baseball or maybe baseball?
Definitely maybe baseball. Definitely probably yes baseball, to be honest.
Because we've been told no baseball for so long, and I think you just like brought me so much joy by even saying maybe.
Hit by the ball. I don't know. How old is he?
He's 4.
Oh.
Like T-ball.
Yeah.
Like talking about is 4 years old baseball.
Hello. Yeah, so like baseball at 4 years old doesn't look like baseball at 10 years old. And so there's absolutely nothing wrong with T-ball and running around and playing. It's that if the child really gets into that sport, what happens is, the coach wants them to do more, wants them to lift weights, wants them to do things that they may not be able to do later. And so most of our guidance is trying to find the right sport that'll be better for life. But there's nothing wrong with exploring things, especially when they're little like that.
So he can do T-ball, but we're gonna have to take it away eventually.
What I would say, I mean, correct me, he's going to have restrictions on how he's able to play, right? And so he could potentially, but it is going to be restricted in some manner. And yeah, that's a really hard conversation at 6 or 7. or 8 or 9, wherever it ends up being.
He's going to have both restrictions that your physicians say, we don't want him to do this or that, like weightlifting. He's going to have restrictions on the basis of the disorder. That's going to challenges, especially to a sport like that. So I mean, it just needs to. Exploration is good, broad-based. Things of activities. Let them try different things. That's what we counsel all people with genetic aortic disease, all children, is to not like identify with one sport and but to
Unless
try
it's
to
golf.
golf's fine. Golf's walking with intermittent.
Golf's good. Cricket actually got put in a good spot. Anyhow. Yeah,
Yeah.
and you'll have them. You can kind of take a look. I do think that the square one, not the list one, is probably the more important. I think the contact level stuff is a bit more clear and understandable. It's that intensity aspect that sometimes gets confusing and hard.
We have time for one more question.
I have a quick question. So we, and this is for both you, Dr. Wishart and Dr. Lindsay. So we, as both of you know, had a full code at home last November, and we were lucky enough to be able to get our insurance to pay for an AED for Raceland. But I remember specifically, I'm thinking after, why in the world did we not already think of that? And I'm wondering, and that was really just to keep them alive, much less play a sport. So I'm wondering if that's something that the two of you would maybe recommend for families to look into also, if it's a possibility while they're playing sports and things.
Most places, so I know like all high school sports are going to be required to have one on site. I'm pretty confident most public sport arenas should, but for the little ones, obviously a little random park around the corner for me that they play soccer at doesn't have one. I haven't thought about that.
Yeah, so AEDs in really small children like wrestling are it depends on that particular child's scenario. So ACTA 2 MSMDS in particular is not one that's subject to the usual type of arrest an AED is useful for. And in fact, most pediatric arrests are respiratory in nature. And that being said, it's a conversation to have if you have an arrhythmic disorder or something, if your particular disease puts you at risk for that type of. Yeah, absolutely. Like Patty was just saying, like, congestive heart failure or some things that put you at risk for an arrhythmia, but MSMDS in and of itself does not. It's usually something that leads to that.
It's helpful because Graceland was ultimately respiratory in but in the moment, it tells you what to do. Like, it doesn't detect the heart rate or low enough heart rate. It still tells you to get questions kind of washed through it. So I felt like it was helpful in that way.
Yeah, it's a great point. Yeah. I think you should have a conversation with your individual practitioners, and it depends on how ill the child is, really.